Welcome back, everyone. We'll now move to our second panel, during which we will hear from service providers and private organizations. The panel will proceed as follows. Angela Doyinsola Aina, Interim Executive Director and Research Lead at Black Mamas Matter Alliance. Then Joia Adele Crear-Perry, who's the founder and president of the National Birth Equity Collaborative. Then Taraneh Shirazian, who's the president and medical director, Saving Mothers, and assistant professor at New York University Langone Medical Center. And then finally, Mauricio Leone, who's the Chief Operating Officer and Senior Director at ObriaGroup. Given some of the topics that come up with regard to maternal mortality, I want to remind our panelists and the public again, and my fellow commissioners, that since 1983, Congress has prohibited the commission from, quote, studying and collecting, or, quote, serving as a clearinghouse for any information with respect to abortion. Please tailor your remarks accordingly, consistent with the statutory restriction. And with that, we will begin with Ms. Aina. Please proceed.
Good morning to the commissioners, the staff of the U.S. Commission on Civil Rights, and my fellow panelists. My name is Angela Doyinsola Aina, and I am the co-founding executive director of the Black Mamas Matter Alliance. The Alliance is a national network of Black women-led organizations and multidisciplinary professionals whose work is deeply rooted in reproductive justice, birth justice, and the human rights framework in order to ensure that all Black mamas have the rights, respect, and resources to thrive before, during, and after pregnancy. We use the phrase Black mamas to represent the full diversity of our lived experience that includes birthing persons and all people of African descent across the diaspora. We are all aware that the US is facing a maternal health crisis. Global data trends have shown that the maternal mortality rate declined in many countries around the world in the last 30 years. But during the same time period, the United States maternal mortality rate rose significantly. Even more disturbing, the maternal mortality rate for Black women is 3 to 5 times greater than that of white women. And ironically, in the US, we spend about $111 billion annually on maternal and newborn care. A recently published March of Dimes report indicated that 54% of US counties have limited or no access to maternity care, and 35% of those counties are considered maternity care deserts, meaning within several areas across the US, there is limited or absent skilled maternity care providers within that county. But presenting raw data alone does not explain the full story of why these maternal health disparities exist in the US. We must take a deeper dive into the root causes of these issues. Black women and girls in the US have been dehumanized and subjected to violence, including enslavement, segregated healthcare, and medical experimentation that entailed sexual and reproductive abuses. Lack of accountability for preventable pregnancy-related deaths in hospital settings, mistreatment of pregnant and birthing people, limitations to quality healthcare and telehealth services, pervasive acts of reproductive coercion, and neglect during labor in hospital settings are all contributors of maternal health inequities experienced by Black women and birthing people. All of these issues are still an under-acknowledged problem in the US. And yes, more research is needed to better understand the nature and prevalence of this discrimination. And under this pressure of a pandemic, these inequities have been further exacerbated. Over the past few years, there have been various legal and legislative actions spearheaded by grassroots organizations, elected officials, and advocates that lay a matrix of remedies to address pregnancy-related deaths. In 2018, the Prevent Maternal Deaths Act was signed into federal law, expanding the state Safe Motherhood Initiative, including authorizing support for state and tribal maternal mortality review committees, allowing states to collect demographic and health condition specific data on pregnancy-related deaths. Though other acts exist to protect pregnant women, mechanisms for filing complaints on the basis of discrimination are not timely to the pregnancy process, and claims based on racial discrimination require a higher threshold of proof. And then further, federal and state laws do little to provide adequate reimbursement for midwives, doulas, and other birth workers who are not physicians that fit a standard insurance system. This creates further gaps within the maternity care workforce. We need new legislation to discontinue the piecemeal approach to eliminating inequities in maternal health outcomes. To see significant positive change, we believe A holistic approach is needed to increase maternity care workers of color through equitable pay structures, provide holistic quality care to pregnant and birthing people, protections for the disenfranchised, incarcerated, and detained birthing people by upholding their human rights. Data collection must also be a priority in new legislation to account for real-time maternal outcomes that offer detailed data useful for clinicians, healthcare and public health systems, organizations and legislators in academia. A recommendation for federal government officials is to help in the fight to end preventable maternal deaths in the US by supporting the Omnibus Act of 2020. If passed, the act has the potential to be transformative for maternal health because it goes beyond addressing maternal death and helps to advance maternal health equity through investments in holistic and community-based models of care, expanding research, and improving technological initiatives to expand access to maternal services. Thank you again to the entire U.S. Commission on Civil Rights for allowing us, the Black Mamas Matter Alliance, the opportunity to provide a statement for today's briefing on racial disparities in maternal health.
Thank you, Ms. Aina. We'll now hear from Dr. Crear-Perry. Please proceed.
Great. Good morning. My name is Dr. Joia Crear-Perry. I'm an OBGYN by training and serve as the founder and president of the National Birth Equity Collaborative, where we create solutions that optimize Black maternal and infant health through training, policy advocacy, research, and community-centered collaboration. As the daughter of Black medical professionals from the Deep South, my dad is an ophthalmic surgeon and my mother is a pharmacist. From very early on, I understood the value of caring for the health and lives of America's most minoritized groups, the descendants of African enslaved in the Americas. While I grew up with those values, my medical education tried to teach me the opposite. Not valuing the lives of Black and Indigenous people is driving the maternal health crisis in the United States, where we are 2 to 3 times more likely to experience maternal death than white women. We are the only industrialized nation where maternal health is on the decline. My daughter, Jade, is more likely to die in childbirth than when I had her over 27 years ago. And in wealthy cities like New York, the disparity is even greater. Black women are 8 to 12 times more likely to die of pregnancy-related causes than white women. We know that the root causes of poor maternal health, racism, and gender oppression inside of healthcare systems and every other facet of society, women of color are more likely to experience comorbid illnesses and report being unfairly treated within healthcare settings based upon their race and ethnicity. The inequities that Black women face have become more urgent as the pandemic and civil unrest show the many ways racism can kill, whether from COVID, police brutality, or hemorrhage during childbirth. But if we know how we got here, we know what we must do and undo to get ourselves out. In wealthy countries like the United States, there is a grassroots and political call to action for a radical shift in practice to reduce inequities in birth outcomes, using respectful maternity care as a model for change. Respectful maternity care is defined as care provided to all women in a manner that maintains their dignity, privacy, and confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during labor and childbirth by the World Healthcare Organization. The National Birth Equity Collaborative optimizes Black maternal and infant health through training, policy advocacy, research, and community-centered collaboration, including respectful maternity care. In partnership with the Institute of Women and Ethnic Studies, Tulane, Ovia, Johns Hopkins, and many others, we have been asking women across the United States, particularly Black women, about their needs. What we have learned has the potential to radically transform what it's like to be pregnant in America. Black birthing people and babies are consistently the most impacted by adverse health outcomes in the United States. Therefore, healthcare systems and quality improvements should be designed with them at the helm. Patients don't need to be more trusting. Healthcare systems need to be more trustworthy. That means treating everyone as experts on their own bodies. That means shared decision-making that places the most marginalized at the center And as I always say, there is no quality improvement without equity. Transforming the maternity care to value Black lives in service of sexual and reproductive well-being could not only improve outcomes in America, but have an impact worldwide. Anti-Blackness and gender oppression are worldwide phenomena. The opportunities and risk that Black people experience, whether in Brazil, Botswana, or Birmingham, have a common thread because of the social construction of race. Whiteness, too, has a global definition. And so when the West transports its medical systems throughout international development and philanthropy, we replicate the American exceptionalism and white supremacy that is killing so many people right here. I am committed to dismantling white supremacy, and I hope you are too. But I'm also just as committed to Black justice, liberation, and joy. And yes, liberation and joy can even be a part of birth. And they are a core tenet of sexual and reproductive well-being that values more than mere survival or the absence of disease. That's what birth equity is all about. So thank you to the Commission for allowing us to present.
Thank you, Dr. Crear-Perry. We'll now hear from Dr. Shirazian.
Hello, thank you so much for asking me to present today. I'm Tara Shirazian. I'm an OBGYN and president and founder of Saving Mothers. We are a 501c3 medical nonprofit. We develop maternal health programs to decrease maternal mortality globally and locally. We have worked around the globe to create low-cost, high-impact programs that unify community and hospital-based efforts to improve maternal health and reduce death. Our programs target the frontline women's health workers. We target the community health workers and birth attendants to enhance their medical knowledge of maternal risk and complication. We empower them to communicate and be heard within the healthcare infrastructure in their own communities. We are frontline maternal health trainers. In 2019, our efforts turned from global to local. Unlike the global setting where health resources are scarce, here where I live in New York City, we have an abundance of resources, yet we have staggering rates of maternal death. Who are most affected? Well, we've already heard from all our panelists. Data from the CDC indicates that nationally, Black women are more than 3 times more likely than white women to die from pregnancy-related complications. Tragically, the disparity for Black women in New York City, where I live, is even greater, where they are 12 times more likely than Black women to die from pregnancy-related complications. In 2018, the severe maternal morbidity rate for Black women was at least twice as high for white women in half of the state's regions. Over 60% of pregnancy-related deaths in New York City occurred antepartum prior to delivery or within 1 week postpartum. So that's the period of time. Maternal outcomes are persistently worse for Black and Latino women relative to white women, even after controlling for health status, sociodemographic factors, and neighborhood income. Maternal mortality has not significantly changed for over 20 years, despite substantial investment in maternal health programs in New York City. Our own comprehensive review of maternal health programs in our city, which is where we started before starting this program, found a lack of programs using evidence-based approaches and a lack of reported outcomes. Despite the investment, the results were not evident. Among the programs reviewed, there was only a single community-based model that addressed adverse birth outcomes, but it did not address maternal outcomes in any way. Hospital-based approaches to decrease maternal death have also failed to demonstrate any change in maternal death. 10 years of global health work with Saving Mothers has produced a clear truth. Reduction in the rates of maternal morbidity and mortality for any disproportionately affected community requires a participatory, collaborative process. Our more recent local projects have also shown this to be true here in New York. To effect real change, there must be a parallel process to train frontline maternal health workers, mothers, and health providers so they can challenge and overcome the disparate outcomes of pregnancy. Systemic racism is one of the challenges affecting Black women and maternal mortality in New York State. Saving Mothers has repeatedly demonstrated that when you advance both the health workers, the doulas, the community health workers, the birth attendants, and the mothers' understanding of basic medical information and hone their communication and advocacy skills, the result is a self-sustaining resilience in families and communities. We've demonstrated this in Guatemala, Kenya, and around the globe. Our M.P.A curriculum focuses on providing frontline maternal health workers with needed high-quality health information and advocacy building skills. The Mom's M.P.A Kit provides a pregnant woman with easy-to-use tools to be more health literate about her pregnancy and communication coaching that will better prepare her to identify and challenge systemic racism and sexism in the healthcare system, skills she can use throughout her life. Phase 1 of our M.P.A program consisted of using participatory and qualitative methods to develop and evaluate the key components of our proposed community health worker training. We learned that current community health worker maternal health training is non-standardized in New York. Community health worker training was varied, and despite their dedication to clients, respondents noted a lack of confidence in recognizing health risks and communicating health information to low health literacy clients. Our M.P.A curriculum and training focuses on identifying pregnancy risks, health literacy, and self-advocacy. We really believe that empowering the frontline health workers, empowering the mothers, empowers their community. And we also believe in teaching and training, again, the healthcare providers themselves. We would further love to collaborate in broader ways and bring our M.P.A program to more cities with larger community and hospital stakeholders. Saving Mothers develops evidence-based, collaborative public health programs that tackles the staggering disparity in maternal health.
Thank you, Dr.
Thank
Shirazian.
you for having me.
That we'll hear from Mr. Leone. Mr. Leone, your camera is off. Well, we may need to come back to Mr. Leone when he can return. At this point, we'll accept questions from the commissioners. Commissioner Degboy.
Sure. Thank you, Madam Chair, and thank you to all the witnesses for your work and for your important testimony. One question I have for you, because we're sort of focused today on the issue broadly, but also on what the federal government is doing and could conceivably do better to move the dial on these issues. And so one of my questions to you is, what is your assessment of where the federal government is in terms of its contribution to trying to eliminate these disparities, and what specific interventions, whether they be policy or legislation based, are you thinking would make sense that the federal government should be taking up?
I see Mr. Leone has returned, so we'll go ahead and take answers to this question, and then after that, we'll turn back to Mr. Leone for his statement. Go ahead, Dr. Shirazian.
I think investing in the communities is extremely important. I think investing in community health workers and frontline workers that serve women in our most marginalized areas is key to overcoming a lot of the barriers. If we want to build trust, if we want to have collaborative programs, if we want our patients to trust us and we want the most underserved to actually come to the hospitals when there is a need, we have to gain that trust. And that's done through community participatory work and also research and showing the evidence for our programs.
Dr. Perry, Crear-Perry.
Thank you. So where we are right now is we finally started to recognize it's an issue. I was honored to be able to present and testify in front of Congress for the one bill that was passed to actually start sending money through the CDC to pay for counting maternal deaths. We went decades without even funding that work, and we have not created a requirement. So the federal government could do is actually require states to count maternal deaths. Right now, it's a nice to have. But we know that we don't value what you don't count. And so you could start tomorrow with the requirement that all maternal deaths are counted. That's a big start. Another thing that we could do as a federal government is actually invest in women's health. And that doesn't just mean healthcare services, transactional services, but that also means paid leave. That also means childcare. I know right now, my fourth grade virtual schooling that I'm trying to do and also testify in front of you all, it's really complicated. And so it's important for us to really think about how we can invest in, as a federal government, women, birthing people, queer folk, people who are supporting families to ensure that they can survive and thrive after having a baby.
Thank you. Okay, Mr. Leone, why don't we turn to you for your statement, 5 minutes, and then we'll go back to the rest of the question and answer period.
Okay, can you hear me?
Yes.
Great. Good morning, everyone. Thank you so much for the invitation to testify and share my experience. My name is Mauricio Leone. I'm the Chief Operations Officer for the ObriaGroup, and I'm here today to present a boots on the ground perspective from the field. We are a nonprofit organization with a national network of more than 20 life-affirming healthcare clinics in several states across the nation. Our target population experiences significant disparities accessing healthcare services and health education. We provide life-affirming healthcare services to anyone in need, regardless of race, ethnicity, age, gender, creed, national origin, or ability to pay. We offer prenatal care services, well woman care, STD testing and treatment, sexual risk avoidance education, parenting education, and pregnancy resources to over 10,000 patients a year, mostly women and minorities. Although we live in one of the most developed nations on the planet, there remain significant barriers to life-affirming healthcare services. We at Obria have observed the following. There are still challenges navigating health insurance for pregnant women, which is a significant barrier to access prenatal care. Although pregnancy Medicaid coverage is widely available in California, and I believe in the nation, for all low-income pregnant women, it is still extremely difficult to navigate or use. There is lack of providers who accept Medicaid for pregnant women. Healthcare providers don't necessarily have a contract with every single Medicaid HMO out there, or don't want to serve Medicaid patients due to the low payments. Others accept Medicaid insurance, but provide lower quality care. There is lack of access to evidence-based primary prevention strategies such as sexual risk avoidance education, especially for the youth population in public schools, which results in higher rate of teen pregnancy and STDs. This is very important because teen pregnancy is linked to lower weight and infant mortality. In spite of the documented benefits of sexual risk avoidance education, in 2016, the state of California enacted the Healthy Youth Act, which intended to prevent pregnancies and STDs in young people. But cases of STDs have just reached a 30-year high in California, or 400% increases in some counties. Sadly, women are more impacted with STDs than men. Unintended pregnancies are also very prevalent in some communities, which have higher rates of pregnancies than the national average. Although there is a positive downward trend in late or no prenatal care, we see a significant proportion of affected mothers who still come in late to our clinics for prenatal care services due to lack of knowledge about their options in the community. Our medical providers have reported that there is very little information available for pregnant women about their healthcare options in the community, including information about their health insurance coverage options for bringing pregnancies to term. There is a prevalence of substance abuse among pregnant women coming to our clinics. This can produce preterm births and have a negative impact on women and babies who are at risk for poor health outcomes. We see the need for risk avoidance primary prevention strategies because they can lead to health outcomes that are improved when risky behaviors are avoided. There is no consistency of follow through with preventive screening and treatment, which leads to disparities in pregnancy care. We see a trend in our patient population that due to low educational attainment and health literacy, patients don't follow preventive health screening recommendations. They usually come to our clinics when they're already overweight, already infected with an STD, or are late in their pregnancy. Lastly, we observe a lack of medical compliance by our pregnant women. There's a small but consistent percentage of patients that don't comply with their care recommendations. This includes complying with follow-up appointments and routine laboratory tests. This is due to transportation, childcare, health insurance, communications, or other psychosocial issues. In sum, there are significant disparities still affecting low-income pregnant women in this country. These disparities have a negative impact on accessing life-affirming healthcare services early in pregnancy, which might partially explain the differences in pregnancy outcomes among different populations. We also think that it's critical to address another social determinant of health that is equally important to achieve positive outcomes for mother and child. Evidence-based risk avoidance education, because it has an emphasis on personal responsibility, healthy relationships, and self-regulation skills. As public health representatives, we advocate for strategies that help low-income women and individuals develop the skills necessary to make healthy choices and avoid risky behaviors. Our goal for every patient is optimal health outcomes. when we have the active involvement of the patient in their care, avoiding risky behaviors, we are more likely to achieve this goal. Thank you so much for the invitation.
Thank you very much. We'll open to continue with our questions from commissioners. Commissioner Kursnow? Oh no, sorry, Commissioner Cladney?
So we've had your testimony and the last panel's testimony, and they've given us a lot of food for thought. But is there a model program in the country and a community that you could cite that handles this problem better than anyone else? And where would that be? And if there isn't one, is there somebody who has proposed a program to move this problem forward?
And panelists, if you raise your hand or unmute, I'll know you're ready to talk. Dr. Shirazian? And then I'll come to you next.
We actually did a review of all the maternal health programs that exist in the US. And then we focused in on New York State because, as I said, I live in New York State, so we wanted to kind of start very local. There are a number of programs that have enjoyed some variation of success and have had elements that have been successful, but there's not like one dominating one that I would say has sort of really been able to do everything. So that's why when I mentioned the Empower program and us starting sort of this program here in New York and starting with the participatory collaborative process of, interviewing all of our community health workers and speaking with them about training and what training they've had to date and what training they would like. And even through this pandemic, we've been doing Zoom training sessions with them, focus groups, and trying to understand exactly what their needs are in order to develop a more comprehensive program. So as I said at the beginning, at Saving Mothers, we are at the beginning stages of trying to develop that type of collaborative, participatory, community engaged program that would start with the community, but then would extend out into the hospitals. And we have models of this that we've done in other communities globally. We're a global women's health organization. So we're in Kenya on the ground doing very similar programs out in the community with the birth attendants, developing training for them that then allows them to be cultural brokers and advocate for women at the level of the hospital and the clinic. So what I'm suggesting is we use some of our global approaches to maternal health and death, apply them locally, use a collaborative community and also hospital-based model, bring those two together, bridge our frontline workers, bring them along with us. We have so many community health workers across this country. Most people don't even know what they do. It's kind of amazing to me. In New York, we have so many community health workers, and whenever I mention them, people are like, oh, those people exist? I'm like, yeah, they go into the homes, they go into the shelters, they talk to pregnant women. They're in the most marginalized regions of the city. So I think we need a collaborative training for our frontline workers that then intersects with our hospitals and our clinics. We get participation from each, and we build a broad collaborative program that way. So we're prepared to work with whatever groups are interested in this, but we really firmly believe that we have a very good training model, and we can start training frontline workers.
Thank you, Ms. Aina.
Yes, what I wanted to add to the question that was just asked is to first and foremost take a step back to understand that the challenges of the maternal health crisis in the United States is very, very complex. So therefore, it requires complexity and diversity in how we address these issues. And it needs to be addressed at multiple levels across multiple sectors. So, for example, we need more supportive federal policy to be passed, like such as the Omnibus Act, that definitely needs to be passed, that will help with a lot of the systems challenges that we see at the state and local levels to get a lot of our public health programs further equipped to actually do these partnerships, these multidisciplinary partnerships, whether we're talking about community-based organizations, with academia, with hospital systems. All of these things need further investment. In addition to that, we know that we need to start creating more pipelines around providing opportunity for maternity care providers, and not just investing only in producing more and more physicians. We need to produce more midwives, more doulas, yes, more perinatal health support workers. And this can look like a multitude of things. And then finally, what I will add to this conversation is that there are several organizations within the Alliance, including the National Birth Equity Collaborative, and several organizations across the countries that are doing this work from a holistic maternity and reproductive health care perspective. There is not one solution to this very complex problem, but we definitely know that there is a significant gap in providing those necessary investments in culturally congruent, community-based approaches to addressing these multitude of issues. And we know that the solution really to make these necessary changes is based at the local level. So that's why we really do emphasize really uplifting and supporting the work of community-based organizations that have been doing birth equity work, providing midwifery services for decades to their communities. And last but not least, I also think it's important to understand that while we do talk about expansion of Medicaid, ensuring that we have programs and educational services around building health literacy, sometimes that can have an assumption that this issue is only impacting low-income people. This issue is impacting people of all educational backgrounds and social economic status. So we have to have a very multi-pronged and multitude approach to this. And we do believe here at the Black Mamas Matter Alliance, along with all of our partner organizations, that we have the solution to that.
Thank you. I'm looking to see if the other panelists, Mr. Leone.
Yes, so I believe there are several universities showing positive pregnancy outcomes with some of the programs. And most of the programs that I know, I don't remember exactly the names of them, but those programs that are showing positive pregnancy outcomes are the ones that are using health education, are investing a lot of time in educating the patients. And I agree with the other panelists that say that we need to embrace this or confront this in a holistic way. So it's not just physical issues that our patients are dealing with, it's also psychosocial issues and spiritual issues and social issues. So if we have these programs that are holistic in nature and address physical issues, but also psychological, emotional, and spiritual issues, I think that patients can have better pregnancy outcomes.
Thank you. Dr. Crear-Perry.
Yeah, I just wanted to add and build on, especially what, so we know despite income or education, Black women are still more likely to die in childbirth than their white counterparts. So a Black woman, the CDC released a report that a Black woman who is college educated and above is 5 times more likely to die than a white woman who's similarly situated. So this idea that if we just went to school, got a good job, got some health insurance, and exercise and moved to a nice neighborhood, that everything would be okay if we were just more not compliant and showed up to all our appointments, is not based on the actual data. The fact is, when we do all those things, we're still more likely to die. So whatever program, to Daniela's point and to Taraneh's point and to Mr. Leone's point, whatever we do has to be comprehensive, but it can't be based upon bias and lack of truth. So the truth is, even when we do all the things that personal responsibility says we should do, we are still more likely to die. And we're not investing in the things that allow for us to have psychosocial and spiritual wellness and joy. So those things require us to actually invest in women's health, regardless of if they're pregnant or not, communities' investments, regardless or not, and not continuing this fallacy that it's because we don't show up to the doctor or because we are not getting access to Medicaid, that those are the reasons we're dying. Because even when those things happen, we're still more likely to die.
Thank you. Commissioner Krishna?
Thank you, Madam Chair, and thanks to the panel. This has been a very informative testimony. Several panelists have testified that structural and systemic racism is one of the principal causes of maternal health care disparities. And this is to anybody, can anyone give me specific examples of what you mean by systemic and structural invidious racism or racial discrimination in systemic structures and medical systems that cause maternal health care disparities on the basis of race?
Dr. Crear-Perry?
Well, since this is my life all day, I feel like I can't help but start. So a specific example is how we structure even the policies around who gets access to care. As an OBGYN, many of us trained in hospitals and facilities where there were only Black and brown bodies. We assume still the legacy and the history of eugenics that the people who we have to train on are people of communities of color, right? So if you go to any place in your cities, in your towns, the hospital training institutions are Black and brown bodies. So what would it look like to create a structural system that said training doesn't mean Black and brown? Training doesn't mean poor people. Training doesn't mean non-centered people. That we train, we invest in ensuring that the people who need the most resource, so those communities, if you're talking Charity Hospital where I trained, or Grady Hospital in Atlanta, those patients actually need the most. They are the most complex patients, and we're sending them to places where there's training, right? We're not investing in those institutions. So both Charity and Grady are always struggling to get budget. That's racism, that's structural. They're begging for money to even keep their doors open. And yet we're sending the most complex patients to those centers. So over and over again, then we get poor outcomes. And we're trying to figure out, well, where the poor outcomes come from? We've never invested in the people who actually need continuity, who need a birth center in their community led by a midwife, has a doula supporting them from their community who's invested in them. That's what they want. That's what we should be investing in. That's a structural decision that we are making as policymakers to not allow for the growth of birth centers, the growth of midwives, the growth of doulas. That's how structural racism works. It devalues groups of people and also institutions and invest in things that are harmful to support the legacy and hierarchy of white supremacy.
Thank you. I saw Dr. Shirazian, you had, oh, sorry. Dr. Shirazian, I saw you had an answer as well.
Yeah, I mean, I completely agree with Dr. Crear-Perry in terms of like how our healthcare infrastructure is set up. I'm also an OBGYN and how systems are set up. I can just give you a few examples from a very like personal perspective, not my lived experience, but certainly the community health workers that I work with and what they tell me and what I actually see as well. So if you're a patient, so I'm just going to give you like an individual patient kind of perspective, but if you're a Black pregnant woman and you come into a clinic, let's say in New York City, and you have to wait 8 hours in the waiting room for care, that is structural and implicit racism right there. Because that, you know, that waiting room, it just devalues that patient, right? She has to wait 9 hours to see a doctor. The clinic's busy. When she sees the doctor gives her 5 minutes to talk to her, to answer any questions. Maybe she's not a sophisticated speaker or presenter. She can't even get out her issues or complaints. Maybe she doesn't know how to articulate them even, potentially. You know, brings in issues of health literacy and how she's heard, whether the doctor hears her, whether he or she understands what she's saying, whether they bother to listen. So, I mean, those are just some very simple examples, but I think, you know, from an individual patient perspective, if you go into these clinics and hospitals or you go to see your doctor and you don't feel valued, you don't feel respected, you don't feel listened to, why would you ever go back? Like, why would you go back if you had a true problem? You know, you're gonna stay home. And that's where we see, you know, sometimes maternal deaths happening because people don't come back in that quickly. You know, I mentioned before, most maternal deaths, at least, you know, looking nationally at the data, they happen before delivery or in that first week postpartum. So if you go home and you had a horrible birth experience and now you have pain in your leg that could be a blood clot, you know, you're not going to raise your hand to go in to see the doctor. you're going to call your friend, someone in your community, maybe that frontline healthcare provider. That's why I say a lot of the solution lies in the communities, because women trust their community leaders. They trust their community health providers. And until there's a day where they can also trust their clinics and their hospitals to listen to them and be respectful and not make them wait for hours, that system is going to take a longer time to change. So that's why I always say community first, educate the community, empower the community. The results lie there.
Mr. Leone, it looked like you had an answer.
Yes, so I just wanted to say that I agree with Dr. Perry that healthcare services is not just what is needed here. What we need is a primary prevention strategy, something that can educate patients when they are young, when they are early in life, so they don't engage in risky behaviors, and then they don't show up with these comorbidities to their care. So again, I agree with her that healthcare is not the only thing that we need to address here. Is also primary prevention, because primary prevention strategies are more cost-effective and efficient than later remediation. So I believe that we need to make an effort in educating the patient early in life. And I believe that sexual risk avoidance education is one alternative, or one good alternative for you guys to consider.
Thank you. Ms. Aina?
Yes, I believe that the question was originally talking about racial and other systemic discrimination in our hospital settings and just around the entire system. We have spoken to several women of varying ages and socioeconomic statuses via focus groups for the past 3 years. And what's pretty consistent is that when they do come into a hospital facility, the types of treatment that they receive tends to be based on the type of health insurance that they have, whether they're on Medicaid or they don't have insurance at all. And many of them have reported actually being discriminated against by healthcare professionals, whether it be the front desk administrators who are not taking some of their complaints very seriously, or they have gone, or they're in the laboring process, and they're trying to explain to their clinical provider of any pain or challenges that they're having, or may not understand why all of a sudden some kind of surgical intervention has been decided upon them without their consent. These are examples of systemic discrimination based upon the fact that, one, basic patient consent to understanding what services are being provided to them is not happening in these facilities. Further, during this COVID-19 pandemic, earlier on in the pandemic, a lot of hospital systems, unfortunately, were passing policies that restricted the ability for different birthing persons to bring their support persons with them, whether that's a doula or somebody else that they wanted to bring with them during that process. And so, you know, these policies get passed at the local healthcare systems level at any kind of realm, depending on what's going on. And so these are, I'm just providing that as specific examples because they do lead to negative health outcomes. And we see that more nationally, unfortunately, I mean, this is very unfortunate. We see that in the story of Amber Rose Isaacs, in terms of, you know, she did everything that she possibly could to navigate the healthcare system in New York. She requested for midwifery services and still wasn't provided that. And unfortunately died after being serviced at the hospital system. We saw that with the situation with Shirazian Washington, who was ignored. Her blood pressure, I believe, was rising and no one attended to her and she still died. So these are actual examples of discrimination in the healthcare system. This is not because these young ladies came into the hospital and they had all these pre-existing conditions. These were preventable deaths that healthcare providers are trained to actually intercede in, and it didn't happen. So that's it. So these are examples of discriminatory acts in these healthcare systems.
Thank you. Commissioner Kirshner?
Yes, thanks very much for that. Dr. Shirazian, I think you indicated that Latino and Black mortality rates are higher than that of whites. And I'm supposing that that's controlling for socioeconomic conditions.
Yes.
How do they compare with Asians?
Black women have the highest rates, then Hispanic, then Asians, then whites. So it was across, I listed here health status, socio-demographic factors, and neighborhood income. It was taking into account all three of those things. It definitely is true that even along socioeconomic lines, Black women die at significantly higher rates than white women.
Thank you.
Dr. Crear-Perry, it looked like you had an answer as well.
I just wanted to, because we talk a lot, we use white as like the default race. And in so many experiences, actually Asian Americans have better outcomes than white folks. So we have to really reframe how we talk about race and the implications of race. You know, race is not biological. I don't have a Black gene. I am just as likely to have the same genetics as Dr. Shirazian has. We are all one human race. We've completed the entire Human Genome Project. So when you think about the differences of how Black women are treated in the hospital and the outcomes we have in birth, it's not because our kidneys are different shaped, or our lungs are different sized, and white women have different kidneys and lungs, and Asian people have different, it's how we are treated and seen in the system. It's how the structures show up when we are addressed. So even as Angela mentioned, we have studies and data that shows, despite payer, Dr. Liz Howell did a study that showed that Black women who have insurance payers, who have good insurance, still get treated worse than their white counterparts who have no insurance, who show up with no prenatal care. So until we can have an honest conversation about the devaluation of people based upon skin color, based upon gender, based upon income, we're never going to fix the maternal health crisis.
Thank you. Commissioner Yaki?
Thank you very much, and thank you, all of you for taking time today on this important topic. I come this from sort of two different angles here. One, I used to be in local government, so I understand and really appreciate and quite champion the idea of locally based, community-based organizations and delivering really critical services to communities. So the other part of me is when I was at the federal level working for the speaker and talking about how do we get the resources necessary to make that happen. And that tension between funding, studies, who controls the studies of this kind of stuff, because we want that information, and then sort of the control, where is it going to be distributed, is really sort of the crux of how do we address this. Are there any good models out there that the federal government can look at to say, okay, this is a kind of mechanism that we can direct dollars to that will achieve these kinds of results that we want to see on the aggregate, but at the local level, produce the kinds of individual changes that we want to see? I guess, are there things out there that the feds can latch on to say, this is how we want to be able to figure out a way to distribute the dollars necessary to meet this critical health need? I see people smiling. That's interesting.
Well, because I'm excited about the opportunity. I'm in a place of justice and joy today, and I'm like, listen, what are we going to do different? How are we going to do something different? So one of my favorite programs in the world is a Healthy Start Association, a Healthy Start program. My first job in maternal and child health was a medical director for the Healthy Heart Start in New Orleans. And this idea that you can actually give money to communities and they can fix their own problem. It was actually a Republican idea, right? This was amazing. We've never scaled it up. We've never invested in it. And it keeps showing the Healthy Start communities have better birth outcomes. We know that through the data, and yet we've never actually invested in it. So we keep doing trickle down, that we give, the federal government gives money to the state and the state tries to figure it out. And you know, as a city person, state city fights can cause that to be a lot of drama. That can be very complicated. Mayors don't get along with governors. All that stuff happens quite a bit. So what does it look like for the federal government to really build out the Healthy Start model, to trust communities with the dollars to do the work? They were doing social determinants of health before the WHO made it up. They've been having housing and having legal aid and having everybody to work on infant mortality for 25 years. So that's the kind of innovation you get when you actually invest in local communities.
Great.
I see Dr. Shirazian has an answer as well.
Yeah, and this kind of talk gets me excited too. So I think that as Dr. Crear-Perry just said, that it really does, as I've been saying, lie in the community. But I do think that we need to understand all the communities that are out there doing this kind of work. I think we need a broad collaborative force that brings them all together. I think we need standardized approach and training, like everybody gets the same, roadmap, not individuals are sort of kind of creating their own, because I do think that consistency is important, because then we have a model that works, we have a plan that works, we have an evidence-based approach. We need better data. I mean, we talked about death rates. We need to track death rates. It's not only in this country, but it's everywhere, by the way, around the globe. I mean, tracking death rates in terms of mothers is horrendous everywhere. But we need consistency in terms of the approach, and we need the training to be consistent. We need the approach to be consistent, and we need to collect data better, because when I did a review of the data, I was shocked. I mean, there's so many groups out there doing good work. I know they're good work, but if I go on a PubMed search and look for like their articles or their published data, I mean, I don't find anything. I find very little. I mean, that's a problem. I need to be able to look there and see the evidence for myself and read it. And people, we need to be accountable for the dollars, right? We can't just give states money and then who knows what happened to the money, right? It didn't go back to the communities. We don't know if there was any change in maternal outcomes or death. That's a problem. The other problem, well, I have one more second, is that people track birth data, right? They look at the babies a lot. They look at, this drives me crazy. Okay, they look at preterm delivery rates. They look at low birth weight, okay? How many years have we been looking at low birth weight and preterm birth rate? Okay, what about the mothers? That's why we're about the mothers. Like, we want to know, did the mothers die? Did the mothers have to come back for other interventions? Did they have surgery? What happened to the mothers? It's not all about the infant. So I think there's this issue of maternal infant health, and the maternal gets diluted under the infant sometimes. And we really, in order to have good programs that actually address maternal mortality, we need to focus on the maternal. We need to focus on the mothers.
Thank you. Mr. Leone?
Yes, so I think that a good idea for the federal government to consider is to fund organizations that are life-affirming, organizations that are providing life-affirming healthcare services. Why? Because we provide healthcare in a holistic way, emotionally, psychologically, and spiritually, and physically. And we tend to spend more time with our patients than other organizations do. So if you can direct funding to life-affirming healthcare organizations, that would be ideal. And we can show that we have a higher patient satisfaction rate too. And also I would like to share with you that the University of California 2 months ago, they came to us because they have a program to serve pregnant women in the local jail in Orange County, California. And they came to us because they couldn't find any other organization in the community that would accept those women. And that is very interesting because the federal government is already funding several federally funded healthcare clinics that are supposed to serve these women. And they are putting barriers to them. So we serve anyone regardless of their ability to pay. And we don't discriminate based on race or national origin. And we are a life-affirming organization. So I believe that if you guys take a look at what life-affirming organizations are doing, it will give you another perspective or an alternative to what is needed in the country.
Thank you. Ms. Aina?
Yeah, what I wanted to add is that, this really does need to take a both and approach and not an either or approach. And I say that because I know it was mentioned earlier about really investing in a lot of evidence-based models and honing in on a standardized training and things of that nature. I do want to lift up that those also actually serve as structural barriers to a lot of our, for a multitude of communities, most especially Black and Indigenous communities, and more specifically for Black and Indigenous midwives Black and Indigenous midwives who practice at the level. We know that across several states, there's different rates of regulation of how midwives can practice. Same thing for doulas as well. And so we really do tout that we need multiple options because just having multiple options around choices is really important for a lot of birthing people across the nation, no matter their social economic status and income. And so definitely more investments in minority serving institutions that can do this type of research to build the evidence of the positive birth and maternal health outcomes that we know that a lot of our communities of color are doing. More investment in nonprofit organizations that can do a better job of not only providing a space for workforce development, but to also provide comprehensive training around whether you're talking about a holistic approach to perinatal health care or a holistic approach to midwifery care or doula care. There's not always this one-sided, one narrow way approach to these things because multiple communities look like multiple different things and have multiple different challenges. And especially, and I have to lift this up, especially for a lot of us in the South region area of the United States. Our rural communities need a lot of programs and services. And we have people in those communities, organizations, academics, people of multiple disciplinary background who are ready right now to engage in a team-based approach to addressing a lot of these issues and need equity-focused investments and not just investments in the traditional players in the maternal and child health sector.
Thank you. I see that we have 2 minutes left for this panel, so I'm looking to see if there's one last commissioner question. Looks like Commissioner Degwe, and we'll do a lightning round to take us home.
Great. Thanks very much. This has been a very enlightening panel. I'm trying to understand if one of the takeaways that we should have from the collective testimony or the aggregation of all this great testimony is that because of the concept of maternal health care deserts and the absence in some communities of access, that part of what we need is more of the sort of birth centers, community localized approach to be reaching folks with interventions. I'm just trying to understand. I get that we have big hospitals and there are issues there, regardless of what your socioeconomic status is in your education. But I'm also trying to get at this gap point. And then the other thing I was a little bit confused about is what is life affirming? I'm assuming that in the plain English, I would guess that all of your organizations are life affirming. You're working on issues that are trying to prevent death and disparity. And so I'm trying to understand what is life affirming and what the opposite is that we're trying to move away from. Thanks very much.
Yeah, so I can answer that question about life affirming, the concept. I would say that life affirming organization is an organization that values life, and not only the life of the mother, but also the life of the baby. So when you have that perspective, when you approach healthcare with that view, with that conceptualization, you really take care, you really pay attention, you really address the needs of the woman and the baby. So if you have that holistic approach to women at the local level, then I believe we can have better pregnancy outcomes as we see in our clinics with higher patient satisfaction and a higher birth rate.
Thank you. Dr. Crear-Perry?
So yes, you're right, Commissioner, that it is a mixture. We believe it's a mixture of local solutions that the federal government can really invest in, more birth centers, more midwives, more doulas, education for culturally congruent. We didn't talk a lot about our Indigenous sisters. And I think there's a lot in the tribal community that we were missing, investing in the tribal community and their maternity care. But the goal, I guess why I brought up that I'm the child of an ophthalmologist is because surgery happens in hospitals. Birthing a baby is not an ICU an event. So all the things we've been doing to fix maternal mortality have been as if we were all ophthalmologists, and we need more technology and hire more bigger hospitals. And what people want, what patients want, is care in their communities, life affirming. Our mission is maternal and infant, so I guess I can start calling myself that too, right? But life affirming care in their communities, ensuring that we are addressing the needs of the people with people who actually look like them.
Thank you. Dr. Shirazian.
Yeah, I mean, I think to fill these deserts that exist, we definitely need community-based organizations. We need community players, doulas, community health workers, all of the community players that help us serve the needs of women everywhere in this country. I wanted to just say one thing about standardized. I don't think that standardized has to be a negative here. I really don't. I think that standardized just means that we have a common playbook, that we can take a program and we can apply it. It doesn't mean that it has to be the hospital or the doctors that design the playbook, right? It doesn't mean that they have to be the ones creating the playbook. In fact, I think that the community investors, the doulas, the community health workers should be the ones laying the groundwork for those playbooks. But I do think that we need to rethink how we talk about standardized, and we do need to have this sort of common, whatever you want to call it, but common model, common playbook, whatever it is, because we need to know what is actually working, and we need to have the data. We just do. Like, we cannot not have evidence. It's
okay, I'm going to move to Ms. Aina for the last point.
Yes, and I would agree. Definitely, we are about wellness. We are about what our people want, and especially to uplift the fact that we should always trust Black women in this instance, and that includes their entire life course. So it is very much life affirming, whatever choice that they seek to make about their lives. And definitely to agree, I do agree with you that we do need standards. And I think that also what I was trying to say earlier is that we need to make room for community-based models of care and practice to help add to those standards. We need to make room for looking at different models of research that uplifts those researchers from these communities that are most impacted, whether we're talking about creating more pipelines for Native and Indigenous people, Black folks, Asian folks, whomever, who are really culturally competent and holistic minded around different research models, and understanding how to collect that evidence to build out the evidence base to show positive and maternal and infant health outcomes. And lastly, by doing that, we also believe that that will help to debunk, right, misinformation that to get pushed in our communities, and anything that seeks to dehumanize our communities through services or any kind of programs that seeks to mystify or shame Black women and birthing people about their life choices around their maternal and reproductive health care. So all of those things are very important. Thank you.
Thank you all. This was just an extraordinary panel. We're very, very grateful to you for your time and your expertise. We will take a brief break now that we have come to the end of our second panel. It will be very brief. We'll be back in 6 minutes at 12:25 p.m. Panelists, you can go ahead and leave the Zoom, and we invite you to resume watching on the YouTube stream for the rest of the next panel. So thank you very much. See you all back in now 5 minutes.
Thank you.